Hello people, welcome to my channel Physio Guide by Divya. In previous video I have explained you clearly the course of the radial nerve. Now in this video I'll explain clearly about clinical features and physiotherapy management also. Once I'm explaining the definition, it's the thickest branch of the brachial plexus and it's a continuation of the posterior cord of the brachial plexus, and the ventral ram and the root value is from the C5 to C8 T1 segments. Now overview, shortcut of the radial nerve, how it supplies means it supplies the three heads of the triceps, anconeus, brachialis, brachioradialis, extensor carpi radialis longus, brevis, supinator muscles, and through the posterior interosseous nerve, and it supplies remaining extensor muscles of the forearm and abductor pollicis longus muscle. Now clinical features. If lesions are high, wrist drop is seen, thumb drop and a finger drop. So if high lesions, there will be unable to extend the elbow. They are unable to extend the elbow, and if low lesions, elbow extension is paired, means little is damaged, but wrist, thumb, fingers is lost, extension is completely lost. Now in high lesions, sensation is posterior surface of arm, forearm is lost. In low lesions, sensation is lost in this, and in low lesions, above sensation, in this sensation are spared, means not that much damage, but lost sensation over first dorsum wet space. There will be loss of sensation in this area only. In acute injury, difficult to evaluate, and we can do this sign, means inability to extend the thumb. We'll ask them to extend the thumb, they'll unable to do. So by this screening test, we can understand the radial nerve injury. Now treatment. In early physiotherapy treatment, early stage conservative treatment is the best for closed fractures, cock-up splint or dynamic splint. After cock-up splint, we'll go to dynamic splint, followed by active and passive physiotherapy management. So if this conservative management is failed, next we'll go for operation. Next we'll go for operation, surgical management after a period of 12 to 18 months. In physiotherapy management, stage of paralysis, it lasts for what we'll treat. In this paralysis stage, it lasts for 2 to 3 weeks. Apply splint to prevent contractures and to decrease pain. TENS is the best, and to control inflammation and edema. Limb is elevated and active and passive exercises to both limbs. Exercises. What are the exercises for unaffected limb? For unaffected limb, active and active assisted range of movement exercises. For affected joints, full range passive movements and passive stretching of joint by patient himself. If the patient himself will do, more results are seen. After post paralysis stage, to re-educate means to improve, to respond of motor and sensory function, motor sensation by diagnosing injury, electrodiagnostic test, and PNF, hold and relax type of PNF technique. Next one, sensory stimulation by electrical stimulation, sensory by cutaneous over the superficial of the skin, proximal of the affected area, and modifications of splint from static splint to dynamic splint, so that they'll do movements properly and they'll improve their movements. So I hope you understood this topic. Thank you for watching this video.